Good afternoon, everyone, and welcome to the first CGNE seminar of the 2022-2023 academic year. We have planned 7 amazing seminars that focus on improving care and quality of life for older adults this fall semester. I'm Janice Whitaker, CGNE Administrator and Community Liaison, and it's my pleasure to serve as host of the CGNE Seminar Series. This program is being brought to you by the Teresa Neese and Helen Diskovich Center of Geriatric Nursing Excellence at the Penn State Ross and Carol Neese College of Nursing, in collaboration with the Office of Outreach and Professional Development and the Center for Nursing Research and Age-Friendly Care PA. Today's seminar is entitled The Past, Present, and Future of Chronic Care in Older Adults. Dyads are timelier than ever. And it will be presented by Dr. Leah Buck, former Penn State College of Nursing faculty and member of our original CGNE leadership team. We're delighted to have Leah with us today. And on behalf of our center and college, I want to extend our congratulations to her on her new role as director of the Sept Center at Iowa. Before this informative seminar begins, there are some disclosures and announcements. Penn State Ross and Carol Neese College of Nursing is approved with distinction as a provider of nursing continuous professional development by the Pennsylvania State Nurses Association, an accredited approver by the American Nurses Credentialing Centers Commission and Accreditation. Participants with a valid RN license who attend the entire nursing continuing professional development program can earn 1 contact hour. Partial contact hours are not awarded. The topic of this education is non-clinical, and therefore we did not identify, mitigate, or disclose relevant financial relationships. In order to earn contact hours, Zoom in and out time will be recorded, and the post-event evaluation survey must be completed. Please be aware the seminar is being recorded. If you have any questions or comments for our speaker, they will be addressed during the Q&A and discussion portion of the seminar. You can enter them into the chat feature, or you can raise your hand and we will unmute you. The post-event evaluation link will be placed into the chat towards the end of this session, and it will also be emailed to you within 24 hours. We do ask that everyone attending the seminar complete the evaluation to give us feedback on the seminar. But it's required for any RN seeking contact hours. Again, certificates will be mailed to you within a month of the completion of the evaluation. And if you have any questions at all, you can reach out to us at cgne@psu.edu. Next, I'd like to introduce Jenny Connect-Frito, nurse practitioner with the Age-Friendly Care PA project and one of our CGNE graduate PhD student affiliates. Thank you for being with us today to introduce our speaker, Jenny.
Hello. So Dr. Buck is a Sally Mathis Hartwig Professor in Gerontological Nursing in the College of Nursing at the University of Iowa. She is also the director of the Sept Center for Gerontological Excellence. In Dr. Buck's 20+ years of clinical experience, she cared for older adult patients across the cardiology trajectory, from open heart recovery to telemetry to hospice. Her strong track record of funded research focuses on developing non-pharmacologic solutions for the wicked problems older adults face in the community. Dr. Buck has been a member of Gerontological Society of America since 2006, where she is a member of the Hospice, Palliative, and End-of-Life Care Interest Group and the Nursing Care of Older Adults Interest Group. She has presented on end-of-life topics at the American Heart Association Annual Scientific Sessions, the Gerontological Society of America Annual Scientific Meeting, the American Academy of Hospice and Palliative Medicine and Hospice and Palliative Nurses Association annual assembly meetings, and other national and international venues. Welcome, Dr. Buck. We are so thankful to have you back.
Thank you so much, Jenny, for that very warm introduction. And at this point in time, we go through that awkward moment where we're making sure that you can see my slides. Could someone confirm on your end?
Yes.
Okay, great. Thank you so much for this invitation. It is like coming home to Penn State, but I would like to call out all of the people from Iowa that are also on this webinar. I was watching in the participants as you came in, and I'm really grateful to see many from Iowa, so thank you. Just really quickly, part of the background for this talk is that individuals are living longer and longer, and particularly with heart failure because of improvements and advancement in clinical care. And so they require informal caregiving assistance more and more, and particularly with heart failure, it can be rather onerous. So the influence of caregiver burden and resilience on this relationship that is trying to manage this self, this condition is really not well understood. And so really my objective today is to compare how dyads and their congruence, and when I use that word, what I mean is, are they on the same page in caring for the patient's heart failure? How this can be influenced by both burdens, resilience, and other studies related to that. So just that's a little bit to get us up to speed. Hopefully by the end of the session, you'll have a greater understanding of dyadic interaction, and that you'll start to think, particularly if you're a clinician, you'll start to think dyadically, not just about the patient in front of you, but also their informal caregiver. First and foremost, let's see, one set of my slides advanced and the other did not. Okay, there we go. Just to kind of define, when I use the word dyad, what am I really talking about? I'm talking about the patient and their informal caregiver. It can be family, can be friends, whoever they call the person that helps them with any type of care. What's interesting is the caregiver, informal caregiver, can provide varying degrees of support, whether it's in their activities of daily living, in the actual, chronic illness management, even just support in their mental health. But I think the key piece we don't often think about is this informal caregiver can either facilitate or impede care. And so to ignore them is not an option. We need to understand, are they helping the patient's care, or are they actually keeping the patient perhaps from obtaining the care that is needed for their chronic illness? But what makes the water even murkier about it is sometimes how we as healthcare clinicians interact with the informal caregiver. Because sometimes, for example, if we're teaching a family member how to provide wound care, we're treating them as a co-provider of care. But if we then in turn ask the caregiver, how are you doing? Is there any way that we can be of help to you? We are now treating them like a co-recipient of care. And so sometimes that just makes things a little bit less clear as the role of the informal caregiver. And the second term that I'd like to define before I move forward and talk about is this idea of typology. And the typology is basically a person-oriented classification system. It is a way, you can almost think of it as a mental map of understanding the ways in which caregivers and patients can interact. And the advantage of using a typology, particularly as we move into a time with larger data sets, whether from electronic health records or even from CMS with some of their large data sets, is it allows for a whole system view of information patterns. It's a way of grouping people into naturally occurring groups and then trying to understand how those groups act in certain situations. So very first thing we're going to do is the past part of it is I'm going to do a really quick overview of basically the last 10 to 12 years of my research, but I've also provided a paper that I sent into the center, which you can request if it didn't come out to you, which will cover this material as well. But this is where it all started. And as an early assistant professor there at Penn State, in trying to, I knew from my clinical practice how important families were in helping older adults manage their chronic illness. I had seen that over and over and over again in years of practice, but now for the very first time, I was looking at it as a scientist and started with interdependence theory. I'm going to get a little wonky for a couple of minutes. This is because I know that there are students in the group. And interdependence theory has its roots in game theory. And where you see it in particular is if you view this table, this 2x2 table, as if it were a checkerboard, and the patient is sitting on the opposite side, and I, as an informal caregiver, or you as an informal caregiver, are sitting on the side opposite the patient, there are one of four ways in which you could play the game. Let's say it's checkers. One, the person opposite you could be really into the game, and maybe you're distracted by other things, or you're just, humoring them. And would be more like those patient does all the self-care. The caregiver is there, but they're just kind of phoning it in. The patient is really doing everything. Or it can be exactly the opposite. It could be that the patient sitting across your checkerboard is very debilitated, no longer able to play the game with you. So you are moving your pieces, but you may also be recommending where they should move theirs, or you're moving them for them. So that is that second type. The third type is that we are equal partners in the game, and we're playing it together and enjoying it in each other in the midst of the game. And then that fourth type is very interesting in that from the original theory, what it says is there is a patient and a caregiver, and they're playing together, but they're not equal. Perhaps this is more like an adult playing with a child or something like that. And so we first conceptualized that fourth type to be that they're complementing each other, that they've taken a divide and conquer approach to the patient's heart failure self-care. So for example, the patient may manage all their medications, but the caregiver is overseeing their diet. That would be a very common pattern with an older adult spousal diet. It might be the opposite if it's an adult child with an older adult patient, that they may do all the medications for their parents, but then the parent is monitoring. So you get an idea that those are the four types, and you see that row one is they're individually oriented, and the row two, they're relationally oriented. Well, what's really interesting about that is, so that's where I started with developing the typology, but now I need to measure it because I'm a researcher. But as wearing my clinician hat, I wanted it to be a very simple and straightforward measurement so that it could be easily integrated into an electronic health record, or that clinicians in a clinic setting could use it. So this instrument that was developed, we give the person a brief definition of what we mean by their heart failure self-care. Then those options that we've given them, and it's a forced choice, they can only make one choice, are the four types, where we sort of describe, and we gave them a little bit of help with that fourth type because, as I said, we called it complementary. So we thought that needed a little bit better defining, but then we asked them how satisfied they were with that. And this instrument is given to both patients and informal caregivers separately to fill out. Then we compare their responses to really get an idea of what's going on in the dyad related to their care for their heart failure. We started with an English version, but since that time, this instrument has been translated into Spanish, Italian, Korean Hangul, and this is Mandarin Chinese. And basically any researcher who reaches out to me who would like to use the instrument in a new language group, we work with their team to make sure that it's translated correctly so that we can compare data across different groups. So this is the compression of what happened after that early conceptual work. And you can see in a series of 5 studies, we are just laying the groundwork. And that's really the piece that I would like you to come away with, is because we were learning things with each one of these studies. And a big shout out to Dr. Judy Hupsey, because study 1, 2, and 3 were conducted as sub-studies in her large R01, palliative care R01. I was one of her mentees, and she was very gracious to allow me to interview some of her participants and then administer the instrument as well. And so what we did first and foremost with the typology was to characterize it qualitatively. Is this, just because it's theoretically true, is it really boots on the ground, accurate? And we were able to very successfully characterize the 4 types that we developed. However, a 5th type emerged, and that was, what if the dyads don't agree? What if one of them says, the patient does everything, and the other one says, no, we work together on everything? So that arose, and we kind of, held it in thought as we move forward, because that next piece was developing the instrument, and then we administered the instrument to, I think it was 27 dyads. But if you read in the paper that it was 29, I always have a hard time with that one, but it was just south of 30 dyads. And at the same time that we administered it to them, we did some cognitive interviewing techniques where we had them talk to us about the instrument, what they were thinking as they did it. It was very clear to them. They had no problems. It was acceptable. They thought it wasn't. It took them 30 to 45 seconds. Most people know exactly how their dyad works. But what we discovered there is, remember the bottom part of that 2x2 table, those 2 relationally oriented dyads, they had a very hard time telling the difference between a collaborative and a complementary dyad. In their minds, both were collaborative. And what we discovered is that whether they work together or separately was often contextual. In other words, the outside context around them might force them to work on the same thing together, or it might force them to do that more divide and conquer model. So we were like, okay, well, it's not good to confuse your dyads that you're measuring. We have to figure out an easier way to do this. So what we do currently is we leave, the instrument has not changed, but on the back end, statistically, we collapse those 2 types, the collaborative and complementary, into one collaborative type. And we have moved that 5th incongruent type into that 4th square. And we can do that mathematically because the constraints of the typology was in that 4th cell, they could not agree, or they weren't doing the same thing. So that's what we felt was like, okay, now we really know that the typology matches what's going on in actual practice. And in the 3rd study, we went back 6 to 8 months later and remeasured the dyads. And at that point in time, remember, these people are in end-stage heart failure, and they were recruited for a palliative care study. And so we only found 10 dyads that were still available. There had been death due to attrition and changes in condition. But of the 10 that we were able to measure again with the instrument, 7 of them fell into the indicated that they were collaborative dyads, and they were the same at time 1 and time 2. Whether the 3 dyads at time 1 that stated that they were individually oriented had all changed. And they had changed because in different directions, but also for different reasons. And that's where that internal and external factor. Example of an internal factor is the health status of one or other member of the dyad had changed. An external factor was the dyad choosing, for example, to go into some sort of congregate living setting. So that we need to do more examination on that. That was more at the case study level because the sample was so small. But that set us up for the next big study where we recruited 150 plus dyads. And one of the things that came out of the original interviews was this life course pattern. In other words, dyads, and this is theoretically supported, if you and someone else are in a relationship together, over time, you've negotiated different ways you're going to handle things. And then as you come up on new situations, you are much more likely within the dyad to handle them the way you've handled similar things in the past. In other words, you can't refight every battle every time. So if you think of yourself with either a significant other or perhaps a parent-child relationship, sibling relationships, any kind of dyads, over time, you have negotiated efficiencies. You know where everybody's buttons are, you know whether to press them or not. And that's what we found with self-care, that dyads just, whatever their game was, not pejoratively using the term game, but the game theory, the technical term, whatever their game is, they will just fold their heart failure self-care in. So in this second bigger study, which was a mixed method study, we were still interviewing them, but also measuring them quantitatively. We gave them an example of a previous task and then asked them to indicate what they, or how they handled it. So for example, we gave 2 examples. We said, do you do taxes together, something like taxes together? Or have you ever done a home improvement project together? How did you negotiate who did what? And then we compared their response to that question to how they had scored themselves on the dyadic interaction. And that was how we could capture that life course pattern, and was very interesting for that. And the second piece that was really sort of transformative for where we were heading was that idea that we wanted to know, and remember study number 3, do dyads shift, or how stable is the typology? In study 4, we asked them specifically, when are you likely to change? Remember we asked them, what's your normal pattern? On working on taxes, working on a home improvement project, and what is likely to influence you to change. And then when we integrated the data with our self-care scale that we were measuring, what they were actually doing related to the day-to-day care, the symptom perception, and then what they did once they noticed that there were symptoms, we found that the life course pattern remained very stable in dyads who reported being more confident. That's what that self-care, self-efficacy scale says. How confident are you that you can take care of your heart failure on a day-to-day basis? How confident are you that you're able to pick up symptoms? How confident are you that when you institute some treatment that you've been instructed by your clinician, that it makes a difference in your symptoms? And they were much more likely to remain in their life course pattern if they scored higher in confidence. Those who scored low in confidence were much more likely to change. In other words, the caregiver, if it was a patient taking care of everything, the caregiver was more likely to step in and take over, or they were much more likely, and I have this beautiful quote from one female caregiver. When I asked her this question, what do you do? She says, because the patient, the report is he had been managing all of his heart failure and he really didn't like her input. And so when I said to her, then what do you do? She says, I call the children. And that's like, I call the Marines, I bring in, moral support to help us do the right thing. Or for many dyads, what they will do at that point is call in the clinician. So it was interesting to see the more confident they are, the longer it took them, though, to escalate. And sometimes that's not always a good position to be in. You can have a false sense of confidence, for example. But the real takeaway for us was, for those incongruent dyads, we found that the caregivers scored very low across all three of these domains of self-care, particularly the day-to-day care. If they were not on the same page, the caregiver disengaged. And, one of our assumptions is that caregivers will give care. But why this is so important for us, both as clinicians and for researchers, is to understand that if there are relational issues going on, you can't make that assumption. And so it's very important to be doing these more relational assessments. There's a greater move now than when I started this work for things like, we call them social determinants of health. But to realize that while we think of that oftentimes on a systems level, in other words, we look at access to care, we look at, social SES, we should also be looking at these more atomistic levels of the actual relationship in which this care is occurring. And in the last study, my colleagues, I had mentioned that the instrument was translated into Spanish, and one of my colleagues over there was using it in a large national project that he was doing related to heart failure. And so we were very interested about the effect of culture on the dyadic typologies. And so I took some of his baseline data and started to just with simple distributions on the dyadic types. I now had 2 US samples. And so I compared it against a European sample to say, are you more likely to have collaborative dyads, for example, in one place than the other? Are you more likely to have patient? And what was very interesting is comparing the distributions across these 3 samples. There were in some areas that sample A of the US was more like the Spanish sample than they were like sample B from the US, and vice versa. And so what that said to us is that this dyadic typology is not not terribly culturally shaped, that we may be tapping into a more basic human relational response. I am sure it has cultural overtones because caregiving occurs within cultural bounds, but it is entirely possible that it has trait qualities that are stable across cultures. This needs further exploration. So that's kind of what, I've been doing over the last few years, but what are we doing right now? And this is the current work. And what's really exciting for me in particular is many of these are being done by some of my mentees, my dyadic mentees. So very excited to give a shout out for the figure I've just popped up here is Dr. Drew Bogalski, who is an assistant professor at the University of South Florida while I was there. And he used, multi-level modeling to really examine, what were these relationships. And I have just kind of come up with something really interesting. All of a sudden my notes have been eaten. So I'm going to refer you to the paper, but what I really want you to understand, the purpose of this study was we were wondering whether congruence, or if you remember that second part of my instrument says how satisfied. We were wondering, is it more important for them to be on the same page, or is it more important for them to be satisfied with the page they are on? And relationships are complex. Relationships over time are even more complex. And it's entirely possible that they have been on different pages the whole length of their relationship, but that's just their game. So we really wanted to tease apart these 2 pieces because the literature was mixed on this point. And so we really looked at, we first of all, looked at the relationship between congruence and how the patient performed their self-care. And you can see those 3 ovals are those 3 domains: self-care maintenance, that's day-to-day care; symptom perception, that is that they're weighing themselves, they're listening to their body, they're noticing maybe are there changes in their fatigue, And then the self-care management is now they've noticed a change. Do they actually do something about it? So we started to look at that issue about, the satisfaction versus the congruence. And you can see their dyadic congruence only informs patient symptom perception. It does not inform the day-to-day care or they're working on a symptom. We've now got a symptom. We have to work together. And so that the more likely that they are congruent, the better the patient scored on symptom perception when measured. And, we kind of hypothesized off of this is that they can be incongruent on day-to-day care, and that's sort of fine. And then we knew from our qualitative interviews that if they're incongruent on self-care management, the caregiver is likely to override it in particularly in a crisis situation where the symptoms are exacerbating. But the piece where incongruence really sucks the life out of self-care is that more subtle in-between state of just tracking over time how you are doing. Is the heart failure stable or are changes afoot? And so that's a key piece to really understand that there are, cost to this incongruence, subtle but real. But the second piece that was interesting as well, and you can see there at the bottom with the caregiver satisfaction with the dyad, it actually had different effects on the patient's self-care management versus the self-care maintenance. So the day-to-day care, the more satisfied the caregiver was with how they're running the heart failure care, the lower the patient scored in self-care maintenance. And what we took that to really be telling us is that probably the caregiver is much more engaged at that point in time, whether because the patient is further along in their heart failure and more debilitated, whatever is going on, that the caregiver is feeling a greater sense of perhaps control, and the caregiver and the patient has perhaps ceded some of that control over the day-to-day. Whereas with the patient self-care management, we're seeing that the caregiver, once again, is perhaps more active. And that's why that the higher their satisfaction, the more likely they are to engage, and particularly when things exacerbate. So this is all very exploratory and needs some confirmatory work. Similarly, and because I'm suddenly glancing at the time and want to make sure that I'm pacing this well, so in that previous study, we're looking at dyadic congruence in the relationship to self-care. Now we're really looking at dyadic congruence and satisfaction in its relationship to quality of life. Because we use person-centered models, it isn't enough that they actually are taking good care of their heart failure. It's also about what is their life like? Is this, how is it working and affecting their quality of life? And so working from the same data set that, the earlier study, Drew Bogalski's study, we looked at different variables, and this team was headed up by Dr. Elian Irani, who is at Case Western and is an assistant professor there as well, and very interested in dyadic interaction. And she, in a sense, repeated some of the same. She used multi-level modeling, a little bit different methodology, but not appreciatively from Drew's study, but I think graphically really gives us that sense of, what is the effect of the dyadic congruence and satisfaction on the quality of life of the dyad. And what we really found was if the dyads are on the same page, that those that are congruent, their caregivers scored higher on mental quality of life. We were using the SF-12 here, so they have a physical scale, and then they have a mental quality of life scale. I don't particularly like the term mental quality of life, but you can think of it as moreover in the emotional, behavioral health, inner weather domains of quality of life versus outside, more physically oriented. So we really see that when they're on the same page, the caregiver is in a better place, relationally, mentally, in terms of their quality of life. But here's the piece. Once again, what the question or what we're intrigued with is it in congruence or is it satisfaction? And what this says for quality of life is it is about satisfaction, that they can be incongruent, but if they're both satisfied with that both the patient and caregiver scored better for physical and mental quality of life. And so it really is that idea that, as you can see for the clinical implications, just that open conversation. You may never get your people on the same page, but if you can get them to a place where we're satisfied with what they're doing, or if you can reinforce, maybe they've never thought about, are we okay with this? I know from my own clinical practice with home visits, I had some dyads that I visited weekly over a long time. And I would often phrase it to myself that their love language was bickering. That was just how they communicated. But then I had the opportunity to see the caregiver after the death of the patient who would be devastated. I would often think that they had been worst enemies for 40 years, but afterwards that caregiver was totally bereft. And then I began to realize that I was misinterpreting their communication style. And that for dyads, probably any communication that goes on and on and on has some secondary gain for the dyad, and I need to be careful before I labeled them. And I think that what we can do as clinicians is sort of help dyads to see that, that the satisfaction piece is more important than they agree on every last little thing. And so the last study, very, very quickly, is an interesting one. I had mentioned previously in our confirmatory steps between our qualitative and quantitative data that we always looked at the qualitative data to confirm what they had scored on their quantitative instrument. And one of the ways we did that was using an I-we analysis, it's called. And what you do is you go through the qualitative data and mark all of the occurrences of either the use of I or the use of we. And we would expect on a dyad who scored as collaborative for there to be a preponderance of we statements related to their heart failure self-care. Whereas on those individually oriented typologies, we wanted to see a preponderance of I or him or her statements. And that's how we really confirmed, is the instrument performing the way we had hoped? And we found that it was actually very easy to do, that you can read. And I just informally, as I was doing qualitative analysis, I would occasionally sort of score them myself just off their qualitative data and then check it onto their instrument to say, are we still tracking here? Well, in this study, Katie and I have, and this is why my notes suddenly disappearing is a little concerning. Katie, I turned in her paper. Oh my gosh. Anyways, that Katie Nelson is a PhD student at Johns Hopkins, and under the mentorship of Martha Abshar, is very interested once again in dyads. And they had some dyadic interviews that they had measured them also in caregiver burden, quantitatively, and resilience. And so they contacted me to say, could we post hoc without an instrument, a dyadic typology instrument, type these people? And so I shared our findings and our analytic strategies. They applied them here. And what they discovered, there were 12 dyads that they had. So a relatively small sample, but they scored you can see 7 of the dyads into those type 2 or collaborative, or excuse me, caregiver oriented dyads, and 5 of them into the type 3 or collaborative dyads. And then they looked at their scores related to burden and resilience. And as it would make sense, they really found that you could see a difference in that caregivers who, I've just pulled up the paper because this was really fascinating to me. So that you could see among the type 2 dyads that the average caregiver burden was higher than the type 3. And that makes more sense. That makes sense, right? The caregiver is doing most of the care, so their burden would be higher, and their resilience was lower. And what they found was that it was an inverse. So for the collaborative, those caregivers scored lower on both burden, and their resilience was higher than on the caregiver. But what I found really interesting was prior to this mixing of the data like this, they had done a thematic analysis, and there was actually a difference based on the typology, so that they had come up with 2 key themes from their thematic analysis. And the first one was caregivers' tendency to take the lead, and the second was the usefulness of cognitive reframing. And so when they brought them together, as you'd expect, the type 2 dyads, those caregiver-oriented ones, were much more likely to endorse that they take the lead, where the collaborative dyads, those type 3 dyads, were much more likely to endorse the use of reframing. So once again, very fascinating work, raising more research questions to be answered, more hypotheses to be tested in future studies. And that's why I really work with this young group of mentees on the secondary analysis in data sets of either myself or other senior people, so that we can really, they can use them as support as preliminary studies for NIH grant applications or whatnot. So where do I, just really quickly in our last couple of minutes, where do I see this going? And so first and foremost, I see it becoming, the issue of dyads becoming more and more important because of 3 main directions that COVID has accelerated. And first and foremost, with the hospital at home movement, it's moving out of the VA. We're seeing more and more of it in other healthcare systems. Basically, we are offsetting more and more care into the home environment. We really need to understand how that works with informal caregivers, and particularly as the dyads are interacting. Telehealth, in a manner of speaking, is also that, is it, particularly with chronic illness, does it make sense to engage the informal caregiver as well on any telehealth visit? And particularly if there's going to be any kind of teaching or problem solving that goes on. The third is the movement with the baby boomers towards more and more people aging in the community. Once again, the informal caregiver becomes more and more of a just a key player on the team, and we need to engage them. We need early, and we need to understand both the facilitators and barriers that they face in providing care. And we need to, as I made the point earlier, not just assume they're going to care, but really to assess how much care are they able to provide, and then what's our responsibility as professional caregivers for the health and safety of patients. And that last point, just I've kind of tipped my hat to it with these present studies and this network that I put together of young mentees, is really there's a need to support the science, the dyadic science in the future. And so I am really committed to that at this point in time. I think at this point, we're going to hit the pause button. Janice, you're going to step back in and talk a little bit about evaluations, and then we'll come back to the Q&A.
Well, thank you so much, Leah, for a very interesting and informative presentation. You certainly have looked very carefully and around that dyad related to patient and informal caregiver relationships and how that impacts caregiving. So thank you for that amazing presentation. As Leah said, we're going to pause for just a few minutes to provide people with an opportunity to complete the evaluation tool. We'll give you a few minutes to do that. Jenny Rank, our CGNE Education Program Specialist, has put the link to the evaluation tool in the chat. We'll give you a few minutes to complete that. And when you've done that, you can place any comments or questions you may have for Leah in the chat, or you can raise your hand and we'll unmute you to ask questions. But we'll be back in just a couple minutes.
And for those of you who may not be completing the evaluations, I put up a beautiful picture of Iowa City if you have never been here. And we are a fellow Big Ten university with you. And I would invite you at this point in time, if you ever find yourself in our neck of the woods, that you drop in and visit us at the Some Center.
If you're still working on the evaluation, please feel free to take the time to complete that now, or you can finish it after the seminar. We will also be sending it to all participants within 24 hours, so you can complete it at least within a week of the seminar to receive contact hours. So Leah, Diane Barish has put a comment and a question into the Q&A. She's saying, thank you for this interesting presentation of your work. I'm curious if there is any data available comparing health outcomes for individuals without a care partner or who have more than just one primary partner, for example, a triad, or more making health decisions, and how they compare to those who are in a dyad situation.
Thank you. That's an excellent question. And it really is interesting because the short answer is yes. There is a significant body of work, and not just in the health sciences, but also particularly when we step over into our colleagues in psychology who have been looking at couples in decision making, and in the communication sciences as well. There's a pretty good body of work related to it. And particularly, so to your the question of the triad, you know, I am not familiar, and I noticed that Amy Rauer is on the call, who is a psychologist and very familiar with the couple literature. I haven't seen, though, does a dyad outperform a triad? I haven't seen them put these different groups up against each other, but it might be a hard, a hard data point to capture. And the reason why I'm making that hypothesis is because family systems theory tells us that you know, dyads can also have, they're nested within family systems. And so a classic example that I sometimes see is, you know, an adult child caregiver where there's several siblings and they may do handoffs. It's not uncommon, particularly if there's one older adult parent left. And so there's all sorts of different configurations. And I actually think it's a great area to do some network analyses because we haven't touched on intergenerational caregiving as well. One of the more complex ones is where the older adult may be providing childcare for the adult child who is working, and the grandchild is actually reminding Nona to take her medications. You know, so there's complex, wherever you have humans and relationships, there's complexity. So I saw another question come up.
Yeah, so, well, Donna Fick had a comment for you. She says, it's great to see you, Dr. Buck, and agree that Iowa is a resource and research rich, outstanding university and geriatrics rich environment. And thank you for joining us. One of the
Thank you
things
so
I was
much.
curious about, Leah, was when you presented the chart from a colleague that you created by a colleague that you worked with in South Florida. There was the patient self-care maintenance portion and the patient self-care management portion. And those terms for me are similar. So could you explain a little bit with a little more detail about, you know, the differences there?
Absolutely. And, you know, just to let you know, once again, that kind of that theoretical piece, I'm using the situation specific theory of heart failure self-care, which drives the science in the in our neck of the woods related to heart failure self-care. It was developed by Barbara Riegel at the University of Pennsylvania. She continues to be a very active researcher and has refined this theory over and over. But the way to think about it, or what helps me keep it straight, is to look at it as it is in that diagram, left to right, so that everybody starts with maintenance. That's that day-to-day care. You know, I get up in the morning. If I have to take medications before breakfast, I take those ones. I then, you know, sit at breakfast and eat a heart healthy diet. This taps into the American Heart Association's, you know, 8 simple, whatever they're calling them now. But it's just that idea. I go to my regular wellness visits. I exercise, you know, I'm careful about being around people who are sick, that sort of thing. That's the main, I want to maintain my health. So that's what you do. The symptom perception, you know, of course, for those who are nurses on here, this is the classic that you actually get up and weigh yourself every morning. And, you know, you are watching for, and you're tracking it, you know, are there any increases in weight? You pay attention to, oh, you know, my ring feels tight this morning, or, oh, I noticed that my slippers aren't fit. You know, those are all places where we kind of tend to put on fluid, which for heart failure, it's all about, you know, the fluid. And then if my clinician has given me a sliding scale on my water pill, I do that. I maybe take an extra water pill as I've been instructed. So that's that. And I've just actually crossed over into management. I notice an increase in my weight, and now I need to manage it. And I do something. Believe it or not, the biggest disconnect for people is that first of all, noticing there's a change and then doing something. That's the kicker right there. And Corinne Jurgens at Boston College has done a significant body of work about how the microvascular changes in our brain actually may be hampering that interoception, that sense of something's not right. And so she's done some interesting work there. But I think denial, you know, that yes, there's some perception issues, but I've had more patients say, oh, I would sit down and take a couple of breaths and I'll feel better, you know, sort of thing. I don't want to think about my heart because that makes me think, and I've got the qualitative data, it becomes existential. We ask them, when you notice you have a symptom, what do you think or what do you feel? In another study I didn't present here, and all of their report is existential. I thought about what would my wife what would my wife do if I wasn't here? Or I thought about my brother, who died of heart failure or things like that. It becomes, and so they don't, we clearly do the teaching, but it's like their thought process has been hijacked by the emotion.
Mm. Well, we have many people putting positive comments about your presentation, including Dr. Ann Kolanowski saying, great presentation, Leah. Olivia Rubio is asking, well, she first says she found your presentation very informative. Did you find that the level of health knowledge or health literacy level, understanding disease progression and treatments of the caregiver impact the dyad relationship and ability to provide collaborative care?
And once again, with a 30-minute period, right, I had to pick and choose. And my work, Dr. Vicki Dixon's work, and others has really done a deep dive into this knowledge and health literacy. The short answer I will tell you is it appears at this point in time, as we've measured, it is not so much, it has to do with actually, they know a lot and they provide evidence of understanding, but the disconnect seems to come in strategies. What do you do? So it isn't enough to teach them, for example, how to read a label, on an item of food to check for sodium content. But, what do they then do? And the dyadic piece can be when that can of green beans whose sodium is just off the roof, the rest of the family likes that. So it's more subtle. Yes, health literacy and health knowledge are well-known factors that impact self-care, but so while they're necessary, they are not sufficient. People actually need to know what to do. I'm in a restaurant and I'm looking at a menu. What do I do?
Excellent points. Solem Lee is asking, could you please share some tips on how clinicians can incorporate this knowledge on dyad typology into clinical practice?
Absolutely. And thank you, Solem, for that question, because one of the mentees that I have is Angela Massoud, who is at the American University of Beirut, but who is also a CNS in their heart failure clinics. And she has integrated this questionnaire right into the electronic health records of their clinics. And it is asked of every single patient that comes in. And if their caregiver attends the visit with them, the caregiver is also asked the question, and it is documented into the healthcare record. So, and it's really funny that I've done all this research on it when I never saw it as a research instrument. It was always meant to be a clinical tool because I'm just a clinician at heart. And this is a funny story. Once again, I can't, present all of my papers, but my instrument, inadvertently, we discovered it actually predicts whether caregivers are engaging with the patients in research. In other words, we had 2 studies in which we really looked at, what parts did the caregivers participate in a research study versus not. And my instrument was predicting that if they were incongruent, or if it was the patient taking the lead on everything, we had way more missing data on the caregiver. And so as a research instrument, it's a twofer. It's also going to help you explain some of your missingness in your data. But that was never the intent. It just happens to do it.
Well, and so helpful. So as Amy Rower is saying in the chat, outstanding presentation on your groundbreaking, theoretically exciting body of work, Leah. Thank you so much for this wonderful talk. And I think she's sharing sentiments by all of us that have participated in this seminar today. So we're unfortunately out of time. Love to continue talking with you more, Leah, but thank you so much for launching our fall seminar series in such a beautiful way. And as always, it's always great to see you.